Hi everyone, my name is Dr. Natalie Groenewoud and I'm a naturopathic physician and one of the medical educational consultants here at DSL. When I'm not consulting or working on education for the lab, I am seeing patients in my gut-specific private practice, and I'm going to be presenting to you today alongside Dr. Amber Sereda, who has identical credentials to me, and we've actually worked together in private practice for the last decade. So Dr. Amber and I are delighted to be introducing our new StoolOMX add-on. This add-on can now be added onto any of your patient's GI maps, and it's providing additional markers to give us clinicians an even deeper level of understanding on our patient's digestion, absorption, and microbial activity. Here is a quick summary of what we're going to be discussing today. Dr. Amber is going to start by taking you through a sample report of the StoolOMX. I will then review digestive physiology. We are both going to talk about the difference between primary and secondary bile acids, their various physiological functions, and what it means when they are high or low. We will also illuminate the various short-chain fatty acids from saccharolytic and proteolytic fermentation so that you can assess microbial activity. We have additionally sprinkled sections of the report throughout this presentation to highlight the different markers that we're discussing. And then lastly, we're going to give you a patient profile so you feel confident on who you would want to consider running this additional StoolOMX test on.
Thank you for the introduction, Dr. Natalie. I'm Dr. Amber, and let's take a look at what this 3-page add-on to the GI map looks like. It includes 25 bile acids and 9 short-chain fatty acids. It can help provide additional insights when looking at the underlying causes of things like IBS, IBD, bile acid diarrhea, altered motility, and more. Page 1 of this 3-page add-on starts with a summary page, and you can gain a ton of information from just this page alone. You get the total quantity of bile acids, the percentages of primary and secondary bile acids. The donut chart below shows the percentages of the main secondary bile acids. To the right of that, we have the LCA to DCA ratio. Next, you can see the summary of the short-chain fatty acids. We get the total quantity and the percentages of the major straight-chain fatty acids, represented both in this bar graph and at the bottom here in the donut charts. Last on this page, in the bottom right-hand corner, you see the straight chain fatty acid to branch chain fatty acid ratio. And we will dive deeper into each of these sections along the way. Here we have page 2 of the StoolOMX add-on, and this page is for those that want to dive deeper and look at the individual primary and secondary bile acids beyond that first summary page. So you can find that here again on page 2. We have 7 primary bile acids and 18 secondary bile acids. On page 3 of this add-on to the GI map, you can find more detailed information on the short-chain fatty acids, with the quantities of the saccharolytic straight-chain fatty acids here, and the proteolytic branch-chain fatty acids here. There's also a visual representation of the physiology on the bottom of this page. And next, we will review some of the basic physiology in order to understand why we would want to add this on to the GI map and understand these markers further. Let's start things off with looking at a general overview of what bile acids are. They are made in the liver from cholesterol. Primary bile acids are conjugated with taurine or glycine. They are then stored and concentrated in the gallbladder. They aid in the emulsification, so the breakdown and absorption of fat. And 95% of our primary bile acids should be reabsorbed in the distal ileum. And 5% should move to the colon to become unconjugated secondary bile acids. Dr. Natalie will now go into digestion physiology so you can see where bile acids fit in, and later she will go into the full cycle of bile acids throughout the body.
Let's dive into the physiology of digestion. It can sometimes be easier to understand physiology first to then be able to conceptualize pathology. In other words, understanding how things should work allows us to identify why or how processes can go wrong. Starting in the mouth. Here we are mechanically breaking down our food with our teeth or chewing, and salivary amylase starts to break down starches. Next, in the stomach, we have stomach acid, which activates pepsin to break down protein into smaller peptides. It's going to aid in the absorption of iron and B12. And lastly, one of the more important functions of stomach acid is to kill off microbes coming in on an individual's food. This is a major line of defense. When food or chyme enters into the proximal duodenum, a couple things happen. First, the acidity of the chyme stimulates a release of secretin. This hormone signals the liver to produce more bile and also prompts the pancreas to release bicarbonate. This bicarbonate will neutralize stomach acid to create a favorable environment for digestive enzymes to work in. The other thing that happens is that when fats enter into the small intestine, CCK or cholecystokinin is released and signals the gallbladder to not only contract, but also for the sphincter of Oddi to relax, allowing the release of stored bile and pancreatic enzymes to flow into the intestines for fat digestion. The liver's job is to produce primary bile acids and to conjugate them with glycine or taurine to make these primary bile acids more soluble. The gallbladder stores and concentrates conjugated primary bile acids. The pancreas produces and releases digestive enzymes amylase, lipase, and proteases. Adequacy of digestive enzyme output can also be assessed by looking at pancreatic elastase or elastase 1 on our GI map, just for your reference. The duodenum, or start of the small intestine, is the main area of chemical digestion. This is where the chyme from the stomach and the enzymes from the pancreas and the bile from the liver and gallbladder all interface and start to break down our macronutrients. The jejunum is the next part of the small intestine, and it is a primary site of nutrient absorption. So it has a large surface area with villi and microvilli and a large blood supply to help with absorption and then circulation of nutrients. The ileum is the last part of the small intestine. Here, B12 is absorbed, as well as 95% of our primary conjugated bile acids are reabsorbed through enterohepatic circulation. Lastly, the large intestine is where water and electrolytes are reabsorbed, and the large bowel also houses 10 to 100 trillion bacteria that ferment fiber, polyphenols, and to a lesser degree proteins, producing health-promoting short-chain fatty acids. These bacteria also deconjugate bile acids by removing that glycine or taurine, and some of these deconjugated bile acids can be further modified into secondary bile acids that have many health benefits. Starting with our primary bile acids, we have 2 unconjugated primary bile acids listed on our test, as well as 5 conjugated primary bile acids. Remember, the significance of conjugation is to make these bile acids more soluble by adding a glycine or taurine. A little cheat to help you remember which ones are conjugated or not can be seen in the start of the name. Toro-chino-deoxycholic acid signifies conjugation with taurine. Glyco-chino-deoxycholic acid signifies conjugation with glycine. Conjugated primary bile acids play a major role in breaking down fats. They do not digest fats, but rather prepare them for digestion. Due to the nature of fat being hydrophobic and the digestive environment containing a lot of water, it'd be really hard to break down fats without bile acids. Bile acids have both a hydrophobic and hydrophilic region, so they can take these large hydrophobic fat globules and break them apart. You can think of this in the same light as soap. Soap helps break down and emulsify grease and oils on your hands, allowing them to mix with water and be washed away. Bile acids emulsify dietary fats in your small intestine, breaking them into tiny droplets so that they can be digested and absorbed. So what actually digests fats is pancreatic lipase. Once a larger fat globule is broken down into smaller ones, lipase can then efficiently attach onto the fat droplets. It then breaks them down into absorbable forms, monoglycerides, and free fatty acids. Micelles are formed from bile acids, lecithin, broken down fats, and fat-soluble vitamins, and these micelles are tiny water-soluble transport structures. They can carry the digested fats and fat-soluble vitamins to the brush border in the jejunum, where they are passively absorbed and moved into the bloodstream and tissues for energy and storage. In the distal ileum, 95% of those bile acids are reabsorbed through enterohepatic circulation. Here is page 1 of our StoolOMX. You can see total bile acids, percentage of secondary bile acids, and the percentage of primary bile acids. Remember how I was saying 95% of our primary bile acids should be reabsorbed in the distal ileum? Well, in this example, you can see that this patient has elevated primary bile acids in their stool. This indicates that reabsorption of primary bile acids is likely compromised, or there is an abundance of bile acids being produced, indicating some level of BAM or bile acid malabsorption. In the table, I also reference what could cause these primary bile acids to go low. Slow motility. If these bile acids spend more time in the gut, gut bacteria have more time to convert primary bile acids into secondary bile acids, resulting in less primary bile acids making it to the stool. Other causes include decreased bile acid synthesis, impaired secretion of bile acids from the liver or gallbladder, efficient reabsorption in the distal ileum, low fat intake, or medications like bile acid sequestrants and antibiotics.
Now let's dive into the deconjugation of primary bile acids and dehydroxylation that happens to give us secondary bile acids. Our beneficial bacteria play two major roles in the conversion of primary bile acids into secondary bile acids, and this is mostly happening in the large intestine. Step 1 is deconjugation. This is the removal of taurine or glycine, making the conjugated primary bile acid into an unconjugated primary bile acid. The enzymes our microbes are using to do this is called bile salt hydrolase. Once the primary bile acid is unconjugated, the next step can happen, which is dehydroxylation. This is taking the unconjugated primary bile acid and turning it into a secondary bile acid. The enzyme that our microbes are using to do this is called 7-alpha dehydroxylase. Here you can see the microbes that use bile salt hydrolase in that first step of deconjugating the primary bile acids. And we can also see here how we can gain additional insights into the microbiome with these StoolOMX markers that add to what we can see on the GI map. Here are the microbes that use 7-alpha dehydroxylase to complete that conversion of our unconjugated primary bile acids into a secondary bile acid. Primary bile acids play a foundational role in fat digestion, and secondary bile acids have several beneficial roles throughout the body. We see that they have antimicrobial properties that help to modulate the microbiome. They have immune regulation properties, which regulate Treg cells, and they also have a big influence on the balance between inflammatory and anti-inflammatory immune cells in the gut. They impact motility. High levels are typically associated with fast transit or diarrhea, and low levels are typically associated with constipation or slow transit. They also have various effects on metabolism and mucosal health. Here is page 1 again of the StoolOMX add-on, and here you see the percentage of secondary bile acids. And when they are high, as we just discussed their various benefits on the last slide, this is generally beneficial. But when they're in excess, they can also cause diarrhea or fast transit time. And when they are low, we want to look at supporting the commensal bacteria.
It can feel like these bile acids are in a bit of a boxing match throughout the day as we eat and during the time between meals. They are transformed, transported, used, recycled, transformed again a couple times, and then absorbed again. So to help clarify this whole bile acid story, I put together this summary. Starting in the liver, primary unconjugated bile acids are formed. Still in the liver, these primary unconjugated bile acids become conjugated with taurine and glycine to make them more water soluble. In the gallbladder, there's a much more concentrated form of primary conjugated bile acids. In the duodenum, conjugated primary bile acids break down fats. In the distal ileum of a healthy individual, 95% of those conjugated primary bile acids are reabsorbed. And then to a lesser degree in the distal ileum, but mostly in the colon, the 5% of primary conjugated bile acids that are not reabsorbed should be deconjugated by bacteria using bile salt hydrolase. And lastly, in the colon, deconjugated primary bile acids are dehydroxylated by 7-alpha hydroxylase and become unconjugated secondary bile acids. These guys play a major role with immune regulation, motility, mucosal and metabolic health, and some of these can also be passively absorbed in the colon. Another marker that you're going to see on page 1 of our StoolOMX test is total bile acids. This is an absolute concentration of both primary and secondary bile acids. Some of the reasons why total bile acids could be high in the stool are bile acid malabsorption, IBSD, increased bile acid production or decreased reabsorption due to liver disease, gallbladder dysfunction, malabsorption, or a high fat diet. Some of the reasons why total bile acids could be low are slow motility or constipation. This allows for more time for those bile acids to be absorbed. A low-fat diet, dysbiosis, reduced bile secretions into the intestine, or decreased bile acid production. We also highlight the LCA to DCA ratio. These are both secondary bile acids formed in the colon. This ratio can be useful in determining the risk of certain disease states and conditions. LCA is thought to be more toxic than DCA due to its inhibitory effects on some of our antioxidant pathways. This ratio being high could indicate an increased risk of colon cancer, and a low ratio could be associated with slow motility, metabolic issues, or may indicate a decreased risk of colon cancer. Here's page 2 of our StoolOMX test. It gives you a detailed table of the 25 different bile acids that we're assessing for. This sets us apart from other labs that generally showcase the 4 most abundant. Table 13 and 14 on our interpretive guide can provide you with more specifics on these individual markers for your reference.
Now let's talk about short-chain fatty acids. This is going to include saccharolytic straight-chain fatty acids and proteolytic branch-chain fatty acids. Short-chain fatty acids are small fatty acids that are 0 to 6 carbons long, and they're produced by bacteria through fermentation of either dietary carbohydrates or proteins. Now, this next part is a little bit confusing, so stick with me. Under the heading of short-chain fatty acids, we have 2 different groups. The first group is our saccharolytic straight-chain fatty acids, which has the same abbreviation as short-chain fatty acids, and these are produced as a result of carbohydrate fermentation. And we expect them to make up about 90 to 95% of our total short-chain fatty acids. The other group under the heading of short-chain fatty acids is proteolytic branch-chain fatty acids, which are a result of protein fermentation. And we expect these to make up about 5 to 10% of our total short-chain fatty acids. Saccharolytic straight-chain fatty acids are markers of fiber and polyphenol fermentation. I've been referring to this as carbohydrate fermentation, and they are also produced by beneficial bacteria. When we see elevated levels in the stool, this is typically correlated with rapid transit time or diarrhea because there's not enough time for the short chain fatty acids to be absorbed. When we see them low in the stool, we're thinking about insufficiency dysbiosis. This is one of the major dysbiosis patterns that we see on the GI map, correlating to low levels of butyrate or short chain fatty acid producing microbes. Inflammation, and we can see this with high calprotectin, can also lead to low levels. Lots of times we'll see low levels with slow transit or constipation because the stool is sitting in the colon for a longer period of time, which increases the amount of time for those short chain fatty acids to be absorbed. We also see low levels in chronic antibiotic use, low complex carbohydrate and fiber intake, and inflammatory bowel disease. Here is another look at page 1 of the StoolOMX add-on, where you can see the percentages of these individual straight chain fatty acids represented in the bar graph, as well as in the donut chart at the bottom. And then we also see the total concentration here. And overall, straight chain fatty acids are the preferred fuel source for colonocytes. They support the intestinal barrier. They're involved in metabolic and immune signaling, and they're very anti-inflammatory. And as we saw on the last slide, these levels are very reflective of the microbiome. This is a chart of the individual straight chain fatty acids that you can find in the interpretive guide for your reference. Many of these you're very familiar with. And on page 3 of the StoolOMX add-on, you can see the quantities specific to the saccharolytic straight chain fatty acids. This chart is showing you the major saccharolytic straight chain fatty acids and the bacteria that produce those fatty acids. And so you can see the vast array of microbes involved in the production of these straight chain fatty acids. This is such a huge benefit of the StoolOMX add-on that we get such a broad view of the microbiome.
Like Dr. Amber mentioned, proteolytic fermentation or branch chain fatty acid production from protein fermentation should only make up 5 to 10% of our total short chain fatty acids. This is because there's a much smaller population of bacteria that have the enzymatic capacity to metabolize amino acids. Bacteroidetes species and Clostridium species are the main bacteria that do contain these proteolytic enzymes. It is important to note that protein fermentation also produces compounds like ammonia, amines, sulfides, and p-cresol. These can be harmful to the colon epithelium. While we don't measure these directly, this is something to consider with excess protein fermentation. If there are elevated levels of proteolytic branch chain fatty acids in the stool, this could tell us the following. There could be impaired digestion with excess unabsorbed protein reaching the colon. Often this is due to hypochlorhydria. We may see slow transit or inflammatory dysbiosis, high protein intake or low fiber intake, low total short chain fatty acids, increased age, and there is association with obesity, chronic kidney disease, hypercholesterolemia, metabolic dysfunction associated fatty liver disease, and IBD. What causes low proteolytic branch chain fatty acids in the stool would be fast transit time, low Clostridia and Bacteroidetes, efficient digestion and absorption in the small intestine, or a high fiber, low protein diet. The table on the left shows the proteolytic branch chain fatty acids and some of their characteristics. The image on the right shows how this is displayed on page 1 of our StoolOMX. For this patient, you can see proteolytic branch chain fatty acid isocaparate is high. This can be associated with proteolytic fermentation commonly of the amino acid leucine when a patient is fasting or has a low carbohydrate intake. On the bottom right of page 1, we can see the straight chain fatty acid to branch chain fatty acid ratio. Again, 90 to 95% of our short chain fatty acids should be coming from saccharolytic fermentation, and 5 to 10% should be coming from proteolytic fermentation. A normal ratio here would indicate that the patient has good fiber and polyphenol fermentation occurring, signifying healthy microbial activity. If this ratio is high, it means that there is an even greater saccharolytic fermentation that's occurring, and this could be the result of the following: a high carbohydrate diet, insufficient protein intake, decreased digestive capacity for carbohydrates, and you might see a low elastase 1 on the GI map in this scenario as well. And lastly, a potentially faster transit time. If this ratio is low, it means that there is a higher proteolytic fermentation taking place than there should be, and this could indicate either low dietary fiber intake, high protein intake, inflammatory dysbiosis, poor protein digestion or hypochlorhydria, and an issue with absorption, a high fat, low carb diet like keto, slower transit time, or increased age.
So what are the testing advantages? As we've been discussing, this is an add-on only to the GI map, which means a single stool sample, which is always a bonus. It's a 3-page report with a summary page on the front, and it provides an expansion of clinical insights to complement what we can see on the GI map. We see key metabolites to further complete the picture of the microbiome. We get 25 bile acids, primary and secondary, 9 short-chain fatty acids, both saccharolytic and proteolytic, and it allows further individualization of treatment plans. More on that next. And it reflects again that collective action of all the microbes in the gut. Let's look at how the StoolOMX add-on can enhance our treatment considerations. In order to start connecting the dots, it's very important to know the stool consistency and motility when looking at the results of this report. I've included the Bristol stool chart on the right here. If it's not something that you're already using in practice, I highly recommend it. It allows further individualization of treatment plans, so it can help you to decide what type of fiber to choose. It may indicate a need for dietary alterations, especially in regards to macronutrient intake, so carbohydrates, proteins, and fats. And we can see indicators of that in the straight chain and branch chain fatty acids. And along with assessing the patterns we see on the GI map and the levels of elastase, we can see additional indicators of weak digestion or low stomach acid. So looking at the branch chain fatty acids specifically. It provides further insights into the cause of motility issues above what we can see on the GI map. For example, excessive bile acids can indicate a root cause of bile acid malabsorption for diarrhea or IBS-D. And in cases like BAM, this can allow you to explore treatment options like bile acid sequestrants, fiber as a binding agent, TUDCA, lecithin, etc. It may also guide you to alter or change a medication based on that medication's mechanism of action if it's altering bile acids or short-chain fatty acids. And on the other side of the spectrum, low levels of bile acids have been associated with constipation or slow motility. So you could consider treatments aimed at increasing bile acids to promote normal motility. And in regards to inflammation and chronic gut lining issues, the level of bile acids and short-chain fatty acids help to refine your treatment suggestions. So high bile acids have been associated with altering the mitochondria in the colonic epithelial cells, which really creates a nice environment for overgrowth or inflammatory dysbiosis, which we would be able to see on the GI map. And when it comes to supplementing with things like butyrate, it can help you to decide when and how much alongside the GI map results. After looking deeper into physiology, the markers on the StoolOMX add-on, and how it expands our clinical knowledge and insights, I want to emphasize when to consider this add-on. Always in motility issues, fast motility or slow motility. So more specifically, in IBS-D, Up to 30% of IBS-D patients have BAM or bile acid malabsorption as their root cause. This is a huge number and is highly underdiagnosed. This test, this add-on, will really help you to see that. Suspected BAM, steatorrhea or fat in the stool, IBD, constipation or slow motility, issues with chronic gut lining or mucosal health, immune imbalances and inflammation, so things like food intolerances or sensitivities, skin conditions like eczema, and those that want to look deeper into metabolic disturbances and aging and longevity. We can gain insights into all of these things from the StoolOMX add-on. Dr. Natalie and I want to thank you for your time and attention. We're here to support you as you incorporate this additional testing into your practice. Please reach out to customer service to schedule a med ed consult with one of our providers for additional interpretation and education support.